Hello everybody, my name is Heather Brown. I'm a registered nurse and instructor with Uric Academy of Medical Arts. Today's presentation will be for our nutrition course on kidney disease. This is chapter 21. So this chapter reviews the medical nutrition therapy for people with various forms of kidney disease. So let's go ahead and get going on this chapter, guys. Here's our first introduction slide on lesson 21.1, kidney anatomy, physiology, and disease. Kidney disease interferes with the normal capacity of nephrons to filter waste products of metabolism. And short-term kidney disease requires basic nutrition support for healing. So here's just a little bit more on introduction. So more than 114,000 Americans are diagnosed with end-stage renal disease, or ESRD, as we'll see in this presentation, each year. Reduced kidney function is often undiagnosed. It requires extensive medical nutrition therapy, and dialysis extends the life but carries high costs as well as risks. So let's start looking at some basic structure and functions of the kidneys. So the kidneys filter about 1.2 liters of fluid per minute. So I like to think of like a 2-liter soda bottle. Everybody can kind of picture that in their mind. So a little bit more than half of that is going to be filtered every single minute. So that's a lot of fluid. So let's talk about some structures. So the nephron, this is our major structure that we're going to talk about. So it has the glomerulus. This is a cluster of capillaries within the Bowman's capsule that filters the blood. So the rate of filtration is the GFR, or glomerular filtration rate. And then we have the tubules. These carry filtered fluid to the kidney medulla. We are going to be looking at this, and I'll point out some of these structures for you guys. So during this presentation, there is a pretty good amount of anatomy. It's not that it's not important, but A&P will go into this in far greater detail. So I'm going to try to stick as much as possible to the basics for this nutrition course. All right, so here we have a couple different pictures. So in it, we can see the nephron in the top left picture. We can see the ureters, which are going to take the urine away. We see the renal artery and vein, so our blood supply in and our blood supply out. And then on the picture on the right, we have the proximal tubule. We have the ureter also seen in this one, the nephron, which is right in the middle, an important area for us, and the glomerulus, you can see on the inside. Picture bottom left, it takes that one segment and it's blowing it up for you. So here we see the glomerulus a little closer, and we see Bowman's capsule that we mentioned on the previous slide. So just taking a look at some structure for you guys. We're not going to ask you to label anything, but these pictures might help you understand where things are located. For some of you visual learners, it will help you piece together when we talk about structure and function. So function, it has an excretory and regulatory functions. So this includes filtration, reabsorption, secretion, and excretion. So I want you to focus on those 4 main points: filtration, reabsorption, secretion, and excretion. So as far as filtration, it removes most particles from blood except for proteins and red blood cells. For reabsorption, substances the body needs are reabsorbed and returned to the blood to maintain electrolyte, acid base, and fluid balances. So that's pretty cool, right? So if the body needs it, it's reabsorbed. If the body doesn't need it, then it will get rid of it. So our body is very smart, thank goodness, that it does this on its own. It reabsorbs what it needs. Secretion, additional hydrogen ions are secreted as needed to maintain the acid-base balance. So we've talked about acid-base balance, and if hydrogen ions are secreted, that's because they have too much, and so we need to secrete more. So it also does this on its own. And as far as excretion, waste materials are excreted in the now concentrated urine. Disease process and dietary considerations. So general causes of kidney disease. So some general causes include infection and obstruction. So a patient may have bladder infections or kidney stones. We'll talk about kidney stones at the end of this presentation, as well as damage from other diseases like diabetes. That was in our last week's topic, or hypertension. and we'll talk about that today. Toxins like environmental agents, animal venom, certain plants, heavy metals, and perhaps drugs. Genetic or congenital defects like cystic diseases and congenital abnormalities. So these are just some general things that can cause kidney disease. So here we have some major risk factors. So risk factors that cause kidney disease include diabetes, hypertension, cardiovascular disease, increased age, so greater than 60 years old, obesity, and also family history of kidney disease. So these are just some general risk factors that lead to or cause kidney disease. Here's a case study. So we're going to be talking about Mrs. Hendricks a couple times during this presentation. So Mrs. Hendricks is a 65-year-old female who has poor glycemic control with her type 2 diabetes of 32 years. She has hypertension and smokes 1 pack of cigarettes per day. Her most recent glomerular filtration rate is 22 milliliters per minute. So what questions do we have about Mrs. Hendricks' condition? So think about this. What questions do we have about her condition? So many, right? If you want to think about it, go ahead, pause your video, and then I'm going to go into just some questions that I have. So my questions are, so she's been a type 2 diabetic 32 years. How does she maintain her diabetes? It says she has poor glycemic control, so she's not doing a good job at keeping her sugars within range. But does she take her medications? Does she check her blood sugar like she should? Is she on insulin and does she take it routinely? So lots of questions about her diabetes. Her hypertension, does she take medications for it? Is she compliant with those medications? Does she monitor her blood pressure? Smoking, how long has she been a smoker? Is she interested in quitting smoking? Does she want resources? So those are just some of my initial questions I have about Mrs. Hendricks' condition. Also in the slide, it says that her GFR or glomerular filtration rate, where all that filtration happens, is down to 22 milliliters per minute. Now the average is greater than 90. She is a little bit older, older than 60. She's 65 years old. So she might have a little decline, but this is quite a significant decline here in how fast her kidneys are able to filter. So lots going on here with Mrs. Hendricks, and we'll talk about it a few times during this presentation. What are some of Mrs. Hendricks' risk factors for chronic kidney disease or CKD? So what are her risk factors? So I have some of her risk factors being older age. So she's 65 years old. That's definitely a risk factor. Her race is a risk factor, as well as her poor glycemic control, her diabetes. That's a risk factor. Her hypertension, the fact that she's a smoker. Remember, smoking causes vasoconstriction, and that's only going to make her hypertension worse. And then she had a problem with her GFR, so that's a risk factor. Her GFR is quite low, like we mentioned in the previous slide. So these are all different risk factors and problems going on with Mrs. Hendricks. What clinical assessment parameters would be useful to find out from Mrs. Hendricks? So what do we want to look at? What do we want to assess? So definitely I would want to assess her urine output. Is she having any? Is she just having a little bit? So I'm definitely interested in her urine output. Remember, her kidneys are barely filtering. So I'm interested in that. I'm also interested in her blood pressure. We know that she has hypertension, but how high is it? I'm also interested in some of her labs like electrolytes. What are her electrolyte levels? I would also be interested in, is she thirsty? Is she taking in a lot of fluid? How's her appetite? Is it increased or decreased? And then is she tired? So does she have fatigue? Is she short of breath? How's her strength? Is she weak? So these are just some of the clinical assessment that I would be interested on Mrs. Hendricks. Medical nutrition therapy in kidney disease. So nutrition therapy is very important for kidney disease. A lot of places that do dialysis have a nutritionist or a dietitian right there on staff because there's such an impact that nutrition therapy plays for this disease. So based on the nature of the disease process and individual responses. So of course, where the person is in their disease process and how they're responding to it is definitely going to impact how they do with this disease. So the length of disease can be acute or chronic. So acute is usually controlled with antibiotics. So if it's just acute right now, something occurred right now, then a lot of times it's not. It can be controlled with antibiotics. It's not something that's going to be a long-term problem. But chronic, it has much more specific nutrient modifications. So like I mentioned, if a patient was going to dialysis, which we'll be discussing, and they have this chronic form, then there's going to be nutrient modifications that are needed. The degree of impaired kidney function, so extensive nutrition therapy is required. So towards the end, definitely extensive nutrition therapy is required. Once again, depends on how the person responds and where they're at in the disease process. Nephron diseases. Now we're looking specifically at diseases of the nephron, which we saw in the beginning when we briefly discussed anatomy. So acute glomerulonephritis or nephritic syndrome. Sorry, those are tough words for me. So disease process, inflammatory process that affects the glomeruli. So that's where our inflammation is. Clinical symptoms would include hematuria, which is blood in the urine, or protein in the urine, possible edema, and as well as mild hypertension. Then we also see oliguria. Oliguria, this is abnormally small amounts of urine, and anuria. This is failure to produce any urine. So we can either have a decrease or no urine present. And medical nutrition therapy, diet modifications, usually not crucial for acute disease. So remember, we said acute disease, if it's just right now, something occurred and the patient just has an acute problem with this. Maybe they had a stone or an injury to that area, or maybe they had sepsis and it caused some problems with their kidney, but they can get over it. So if there's a condition like that, then they don't usually need to do a long-term diet modification. They treat the underlying cause, and once they treat that underlying cause, this will go away. That's at the bottom when they're saying usually not crucial for acute. So those acute problems, not usually significant. Lesson 21.2, treatment of kidney disease. So here's our next kind of introduction information for this next lesson. So the progressive degeneration of chronic kidney disease requires dialysis treatment and nutrient modifications in accordance with each individual's disease status. So we're moving from kind of the acute things into more the chronic things. And here we're saying if it's a chronic disease, then we're going to require that nutrient modification. Current therapy for kidney stones depends more on basic nutrition and health support for medical treatment than on major food and nutrient restrictions. So for chronic kidney disease, things that require dialysis, we need those modifications. But for things like kidney stones or we don't need those significant modifications. We're going to treat the kidney stone, work on the kidney stone, and once it's resolved, we're not going to need those long-term nutrient restrictions. Kidney failure. So with acute kidney injury, it's life-threatening and thus a medical emergency. The disease process. So we have pre-renal, intrinsic, and post-renal. So kind of where the problem is. So pre-renal, this is where we have inadequate blood flow to the kidneys and subsequent reduced GFR. So if it happens before it hits the kidney, so if the problem is before the kidney, we have a blood flow problem. So if the blood flow is decreased, then the kidneys aren't going to get enough blood supply, and what's going to happen is that GFR or that glomerular filtration rate is going to decrease. If the problem is intrinsic, this is a problem with damage to the part of the kidney. And if the problem is post-renal, so after the kidney, that's where we have an obstruction, of the urine flow. So as the kidneys filter, then we have the ureters and the urine going out. If the problem is after the kidney, post-renal, that's where we're going to have an obstruction of urine flow. So we can have problems in different areas, pre-renal, intrinsic, or post-renal, so before, in the kidney, or after. Acute kidney injury. So we have rifle classification utilized for acute kidney injury. That rifle classification basically classifies the severity of the kidney disease. So they have risk, injury, where actual failure happens, loss, and then potentially end-stage kidney disease. So that's a classification system for the severity of kidney disease. So some clinical symptoms may include nausea, vomiting, fatigue, perhaps swelling in the lower extremities, itchy skin, and even confusion. Diagnostic criteria, so there is an increase in the serum creatinine. So this is a level that we measure in patients' blood. So we see an increase in serum creatinine and oliguria. Remember that oliguria is abnormally small amounts of urine. So now we're moving into the chronic stuff. So chronic kidney disease, CKD. So we are moving from acute to chronic. Remember I said chronic this is long-term. This is going to require more severe diet modifications and depend on the person's disease process. So disease process, it's a progressive breakdown of kidney tissue. Most often results from metabolic diseases with kidney involvement, primary glomerular disease, inherited diseases, and other causes include immune diseases, obstruction, infection, and long-term use of nephrotoxic medications. So patients can have a lot of different risk factors. We talked about our case study patient, and they had some risk factors. So modifiable risk factors include blood pressure, so glycemic control, and addressing lipid panels. So these are some things that people can modify. Other things that come to mind is sodium intake. Remember that water follows sodium. If sodium intakes are high, patients are going to retain a lot of water. It's going to put extra stress on the kidneys, whose main job is to filter. Another risk factor would be smoking. So quitting smoking. Smoking causes vasoconstriction. Vasoconstriction creates more pressure. So more pressure, more fluid, and this all overwhelms the kidneys. So it also overwhelms our cardiac system that we're discussing in today's lecture as well. So lots going on here. I just kind of included a lot of that side for those of you trying to piece this together and connect cardiac with kidneys and kind of trying to put this all together. Chronic kidney disease, or CKD, clinical symptoms. So CKD clinical symptoms. So we have dilute urine. So very dilute urine. The nitrogen retention of urea producing azotemia. So that is basically where there's nitrogen in the blood. So, and then we have electrolyte balance, metabolic acidosis. We have anemia. So anemia results because the kidneys cannot perform their normal function of stimulating RBC production. So it can result in anemia, as well as hypertension. So when the blood flow to the kidney tissues is increasingly impaired, so as that blood flow coming in is altered, then renal hypertension develops. So these are all some different symptoms of chronic kidney disease. Here's some more signs and symptoms. So we have progressive weakness, shortness of breath, fatigue, anemia, swelling in the extremities. Remember, lack of filtration, and we're having very dilute urine, so we end up with swelling in the extremities, itchy skin rashes, possible anorexia, vomiting, perhaps diarrhea, and worsening weight loss. Medical nutrition therapy. So here's where that medical nutrition therapy is coming into play for these chronic kidney disease patients. So it needs to be monitored at regular intervals. We can't just go lengths of time without monitoring these patients. So therapy, I'm going to go over each one of these, but I don't need you to memorize the numbers, okay? So protein is usually limited. So it's limited initially. We'll talk about protein once dialysis starts, but it's usually limited to 0.06 to 0.8 grams per kilogram of body weight. Energy, 23 to 35 kilocalories per kilogram per day. Sodium and potassium may be restricted, so think water balance here. Phosphorus and calcium. Phosphorus may be restricted, generally to 800 to 1,000 milligrams per day. Vitamins and minerals, they help patients meet needs for B complex vitamins and vitamin C. And fluid intake is balanced with output. So if the patients aren't urinating a lot, then what comes in needs to balance that. Remember, kidneys are not working very well. Our filtration is decreased. So if we're taking in a lot and we're not able to filter that, then we're going to retain it. So for these patients, we really want to monitor what they take in. What they take in should balance what they urinate out. If we have an imbalance, then they're going to retain even more fluid, putting more stress on this whole system. Once again, guys, you don't have to memorize these numbers. We're just trying to connect here our nutritional therapy for our chronic kidney disease patients. So Mrs. Hendricks, what stage of chronic kidney disease do you think she's in? So think about this. What stage is she in? We didn't talk a lot about the stages. It is in your book to reference, but she is in stage 4. So she's got severely decreased GFR. That filtration rate was all the way down to 22 milliliters per minute. So for stage 4, it's usually 15 to 29. So Mrs. Hendricks is in stage 4 of chronic kidney disease. All right, so we want to outline appropriate medical nutrition therapy plan. So everything we saw in the last couple slides, so focusing on nutrition, what do we want to do nutrition-wise for Mrs. Hendricks? So we want to reduce protein breakdown. We also want to make sure what comes in goes out. So we want to avoid dehydration, but we also want to avoid excess hydration. So we want to match what goes in with what comes out. We want to keep an eye on her electrolytes and correct if needed. We want her to maintain her appetite, and we really want to focus on keeping her morale up and potentially restricting sodium. So remember, water follows sodium, so we really want to keep an eye on her sodium intake. Of course, we'd want to supplement if needed with B vitamins or C, keep an eye on the phosphate, calcium. These are just some of the nutrition therapy plan that we would have in place for Mrs. Hendricks. End-stage renal disease. So disease process. This is the end stage. This is where the patient, family, and physician face life support decisions. So this is at the end of the problem with the kidneys for our patients. Irreversible damage to majority of the nephron. So think back to that initial anatomy where the nephron is. Options are long-term dialysis or kidney transplant. There's 2 types of dialysis. We can have hemodialysis or peritoneal dialysis. We're going to be going into those forms of dialysis now. So this is end-stage renal disease, and now we're facing the decision of do we want to do dialysis or do we want to see if a transplant is an option? At this point, those are going to be the patient's really only options to sustain life. Now we're going to be going into hemodialysis. Hemodialysis, we have a picture of it, but let's talk about it first. So this is where an artificial kidney machine removes toxins and restores metabolites and nutrients to normal. So patients usually get 3 treatments a week. So patients will have a specific schedule like Tuesday, Thursday, Saturday, and that's their dialysis schedule. Typically it's 3 treatments a week. Some patients can have less, some patients can have more. That's just a kind of a typical amount. So medical nutrition therapy, so protein. Concern of patients on dialysis. Dialysis does allow them to have more than before beginning dialysis. So we have protein that can now be increased. So when patients with chronic kidney disease begin dialysis, they can increase their intake of protein. So I'll go ahead and repeat that. So when patients with chronic kidney disease begin dialysis, they can increase their intake of protein. So they're basically going to increase their protein to 1.1 to 1.5 kilograms of body weight. So we see more protein intake here. Energy, 25 to 35 kilocalories per kilogram per day. Sodium and potassium still restricted. Phosphorus and calcium monitored, perhaps limited. Vitamins and minerals, we want to achieve the DRI. And fluid limited to 1 liter per day plus the amount of urine. So some dialysis patients still urinate, maybe small amounts. So if they urinated, say, 300 mLs per day, not much at all, then they could have 1 liter plus 300 mLs, depending on what they were urinating. If they were still urinating quite a bit, say 800, then they would have more fluid that they could take in. Remember, what comes in needs to go out. So if it's coming out, then they can take more in. Here's our picture of hemodialysis. So right in the middle of the top picture, we have the dialyzer. So this is our artificial kidney, okay? This is what works like a kidney. So top picture right in the middle. So that's our artificial kidney. It's going to do that filtration that our kidney should be doing. On the right, we have the patient's arm. So they're removing the blood and it's going through this process all the way to that fake kidney where it's going to be filtered, and eventually it's going to have the clean blood go back into the body. So we're going to remove the blood, we're going to officially clean it, filter it, and then put it back in the body. The picture on the bottom is just taking a look at that artificial kidney in closer detail. Not things for you to memorize. I just want you to see that the bad blood's going to come out, it's going to be cleaned with that artificial kidney, and then it's going to be put back into the body. And that's what hemodialysis does. So here we have the different ways that patients can go through hemodialysis. So the three basic kinds of vascular access, so how they perform this dialysis. So in picture A, we see an AV fistula. So picture A is an AV fistula. So we have what comes in and what goes out. So we see an arrow, it's going out and then it's coming back in. In picture B, the patient can have a venous catheter. So this is going to the vein. You see it being blue, it's a venous catheter. In picture C, we have an AV graft. So a graft between the artery and the vein. So they're looping it around so that way they're connecting the artery and the vein. So for blood supply, so the patient can have their hemodialysis. So these are the three basic kinds of vascular access for hemodialysis. So the next type of dialysis we're going to talk about is peritoneal dialysis. So we have hemodialysis and peritoneal dialysis. Now only a small percentage of patients are on peritoneal dialysis, about 6%. So the treatment here is daily, it's expensive, and patients perform these themselves. So instead of going to a dialysis facility where they're going to utilize that artificial kidney for hemodialysis, these patients are performing this generally at home. Very expensive. Now, what I want to point out is our dialysis patients are usually not very compliant. They ended up on dialysis typically for poor control of their disease process as well as other risk factors. So most patients are not going to be doing this peritoneal dialysis. They perhaps don't have the self-control. That's why we see very small percentage of patients that do this method. So for many of our dialysis patients, the best way for them to get their dialysis is hemodialysis, where they have to come into a facility to get it done. So we see a small amount of patients that are going to utilize this peritoneal dialysis. So this is where we have an exchange of fluids within the peritoneal cavity, and it allows the patient to be more mobile. So for hemodialysis, they must sit in a chair and they have to stay there for hours as their blood is being filtered. So medical nutrition therapy for these peritoneal dialysis patients, we want to have a limit on sodium and potassium. The intake is slightly more liberal, And other things are the same as hemodialysis, protein and energy, phosphorus and calcium, vitamins and minerals, as well as fats. So basically the same, but we have a little bit more sodium that they can take in. Here's our picture of peritoneal dialysis. So the patient has a permanent catheter, so we see that in the picture, and then they connect themselves to this set of tubing that's basically going to filter in their peritoneal cavity and then drain out. So the peritoneal cavity is the space between the peritoneum that surrounds the abdominal cavity and the visceral peritoneum that surrounds the internal organs. So it's going to be right in their abdomen, and what's going to happen is they're going to hang solution. It's going to filter through that cavity, and then it's going to drain out the drainage bag. So this requires a lot of compliance on the patient's part. So they have to be responsible for doing this. They have to do this daily. So like I said, very not utilized nearly as much as the hemodialysis. Transplantation. So this improves quality of life and survival. It's more cost effective than maintenance dialysis. So that's kind of scary, right? So getting a transplant can be more cost effective. So dialysis 3 times a week, going to a center with RNs and staff taking care of them, extensive dietary management for years, very expensive. So transplantation can actually be more cost effective, a little bit scary when you think about it. Waiting lists can be long. Waiting lists can be long and donor matches difficult to find, even when using expanded criteria donors. So transplantation, I will tell you that many of our dialysis patients are not going to get transplants. There's going to only be a few patients that get new kidneys. So think about our patients, non-compliant, haven't followed their restrictions perhaps from their provider, and are now on hemodialysis. It's going to be very rare that these patients get a new kidney. So it is possible. It's more cost effective, but it's going to be limited that we see this occurring for these patients. End-stage renal disease, ESRD complications. So complications of ESRD and dialysis. So our patients can get bone disorders, malnutrition, anemia, hormonal and blood pressure imbalances, depression, and reduced quality of life. It's a lot for them to go to these facilities 3 days a week. It's very exhausting for them. It takes over their entire life. So we can definitely see depression in these patients. Nutrition support, so enteral or parenteral feedings customized to dialysis. Osteodystrophy or neuropathy can also be complications. More end-stage renal disease complications here. So we can have osteodystrophy. This is a bone disease and disorders common in CKD. We have a decreased activation of vitamin D, which creates a cascade effect. Neuropathy, we have toxic substances that accumulate in the blood, resulting in uremic state, damaging nerves. Peripheral disturbances common at initiation of dialysis, and patients should be periodically assessed. So we always want to keep a special eye on our patients. These end-stage renal disease patients have a lot going on. Their conditions change rapidly, so we want to periodically assess them. All right, guys, now we're leaving chronic kidney disease and dialysis into the world of kidney stones. So the etiology or the cause of nephrolithiasis is unknown. Factors relating to urine or urinary tract environment contributes to formation. So present approximately 7% of US women and 11% of US men develop kidney stone or kidney stone disease. Major stones are formed from one of 3 substances: calcium, struvite, or uric acid. So these are our major stones are formed by one of these 3: calcium, struvite, or uric acid. So these are going to be the stones that we cover in the last part of our presentation here. Calcium stones. So these are our most common types. These are approximately 80% of our kidney stone cases are calcium. So the most common type of kidney stone is comprised of calcium. Possible causes include excess calcium in the blood, so hypercalcemia, or urine, so excess calcium in the urine. So the way that they can get this is long-term mega dosing. So more than 2 grams per day of vitamin C is a possible factor. So our patients that take a lot of vitamin C, so more than 2 grams per day, and dietary calcium intake inversely related to stones. So how much calcium they're taking in can contribute to these calcium stones. Remember, calcium stones, this is our most common type of stone. Struvite stones. So these are a lot less common. So these are only about 10% of all stones. So struvite stones, they are a type of hard mineral deposited that can form in the kidney. So struvite stones, these can grow very quickly and eventually block the kidney, ureter, or bladder. So struvite stones, 10% of cases. They're caused primarily by UTI. No diet therapy is needed and usually surgically removed. And lastly, uric acid stones. So these are caused by impairment of purine metabolism with some disease. So a purine is a food or a drink that your body converts to uric acid. So a purine. I'll repeat that. A purine is a food or drink that your body converts to uric acid. So this takes about 9% of stones are uric acid stones. Risk factors, sorry, my words are just all over the place. It's Saturday morning here at my house, and I don't think I drank enough coffee. So risk factors: overly acidic urine, excess urinary excretion of uric acid, and low urine volume. Dietary consideration. So we'd want to avoid food and drink with purines. So remember that purines are food or drink that your body converts to uric acid. So this is a uric acid stone, so we want to avoid those purines. So this includes alcohol, some fish, and some meat. So some fish are like anchovies, sardines, and some meat include bacon, turkey, veal, things like that. So for patients with uric acid stones, we want to recommend diet low in purines. Clinical symptoms of kidney stones and medical nutrition therapy. So now we're talking about symptoms of stones as well as how nutrition can treat. So symptoms include severe pain, urinary symptoms, and weakness, and perhaps fever. Medical nutrition therapy depends on the type of stone. So we talked about the 3 types of stones and modifications that could be made depending on which type. So energy, customized to ideal body weight. So intake is going to be dependent on our patient's weight. Protein, so we don't want to take in any more than the DRI. Calcium, normal. Sodium, less than 2,300 milligrams per day. Potassium, more than 4.7 grams per day. Vitamins and minerals, so limit vitamin C to DRI and others meet. So we want to make sure that we're not taking in too much vitamin C. And fluid, high intake. So large fluid intake is the primary therapy that helps produce more dilute urine and prevent accumulation of materials that form stones. So large fluid intake is the key here. So that would be the first recommendation for any type of kidney stone, is to increase the fluid intake. So this is our last slide. I'm sorry, I know my words were a little all over the place in this presentation. Like I said, it's Saturday here for this recording, so I hope it didn't impact your guys' learning. I know it's a lot of information, but in my opinion, this is kind of where nutrition heats up, because we're starting to see some of those things that we learned in the early weeks now into things like dialysis and kidney problems and cardiac problems. So for me, this is where it's more interesting. Hopefully you guys enjoyed this presentation. Once again, apologize for my strange words this morning, and I hope that you guys are all doing great. Thanks, guys. Have a great day.